aside from all that you've heard so far on classification of dry eye, what we are interested with when a patient sits in front of us is you care a tuppence what it is. You don't need to know what it is only so that you can treat it correctly. So sometimes you get these straightforward dry eye which tells you it's a dry eye. Patient tells you my eye feels dry, and then there is no question. But sometimes there is an allergic element to it. Sometimes there is an infection. Sometimes two out of the three are present. Sometimes all three are present. And then you don't know what to mix and match as far as treatment is concerned. So let us see if in a practical way, if we can find out what exactly is troubling the patient. Is it allergy? Is it infection? Is it dryness? Or is it a combination of all of these? So it's easy when there are classical features. You have classical features, and to make them less classical, they put on the lights. So, but if you had the lights off, the features would be more classical. You get giant papillae over here. You get giant, you get this ring thing over here of allergic conjunctivitis. So it becomes very, very easy that this is an allergic patient that you're dealing with, and you can treat it as per allergy. Or there is infection. This is a slide borrowed from Dr. B Maskati's collection of about 1956 to show you that conjunctivitis pictures haven't really changed. They fade a little with time. But otherwise, you get this mucus debris, you get this conjunctival congestion, not the limbus, you know, all you've been taught with all this muck coming out of the eye. Patient says that he has to clean the eyes are stuck in the morning. Both eyes usually affected if it's an epidemic. So this is a conjunctivitis, it's an infection. Or you get dry eye when the patient is a computer programmer. He gives you history, he says his blinking is problems, or you talk to him and you find that the blinking is an issue. Or you look at the lids and you find that there is oily stuff, this meibomitis, or that there is some the crusting, which is the squamous blepharitis, and there is a little bit of stringy mucus coming out like this over here, which if the patient is in your waiting room and is nothing better to do, like they like to dig the nose, they sometimes like to pull this stringy mucus out. They pull it out like that, it comes out like a strand. So this is all classical images of dry eye patient. And of course, if you did test, you'd find the Shermas being less, and the breakup time, and the rose Bengal. Don't use rose Bengal, it's irritant. Unless you don't like the patient, you want to bugger him, use rose Bengal. Otherwise, in your practice, use Lissamine green, gives you the same effect. You have to wait for a minute or two for the staining to occur. So you get this classical stain. So this is a classical dry eye patient. Unfortunately, you don't get it all so easily compartmentalized. What about allergy and dry eye? It's common. If a patient is an allergic conjunctivitis patient and has been using anti-allergic medicine for a long time, either because of the medicine or because of the preservatives in the medicine, you might get an allergic component with the dry eye component. How do you diagnose it from history? Patient says that he feels burning sensation or a sandy feeling or a foreign body sensation along with itching. An allergic conjunctivitis patient will tell you, I feel itchy all the time, itchy, that's the thing, maybe itchy and photophobia. But if there is a dry eye component, he tells you he feels itchy, yes, but he also feels a little burning or a sandy sensation. So this alerts you that along with the allergy, there is a dry eye component. How do you diagnose it? By a simple therapeutic test, add preservative-free lubricants to the allergy treatment. This is a patient who's known allergic patient, so you've already got anti-allergic. To that, you add very frequent lubricants which are preservative-free. So is the patient, call the patient after a short follow-up, is the patient significantly better? It should be significantly better, so then you know that you're dealing with this combination. It's very simple. Always beware of keratitis or conjunctivitis medicamentosa. This is again a confounder. A patient comes to you, so that was an allergic patient who had a dry eye component, not so difficult. Patient comes to you with a picture like this. Now, it's just a general redness of the eye. He's got no previous history of allergy. This is an adult patient, it's not a child. He comes to you with a generalized little mild chemosis that you can see over here, little bit of lid edema that you can see over here, and you don't really know what it is. Ask for history. They will take out 27 drops that they've used before. So they will take out their bag. If it's a lady, she has a big bag. If it's in my clinic, she has a Prada or a Louis Vuitton bag. But in other clinic, it may be a plastic thali, but they will come out with 27 eye drops which they've used in the past. Or they will tell you that they've used some drops which they have left behind at home. What is this? What should alert you to this condition called conjunctivitis or keratitis? Simple, if it's corneal involvement, you call it keratitis medicamentosa, but otherwise this is a very underdiagnosed condition. So symptoms are there is initial improvement in the original condition requiring treatment. So patient had started out with a simple, say, infective conjunctivitis. Patient was better with the treatment. They tell you that. Then they tell you that apparently the patient became worse after some time of becoming better. Though they were complying with the doctor told me put it 6 times, I was putting it 6 times, but I was better and then I became worse. That is one indication. Or the patient changed the doctor because he was not comfortable. He was better, then he went to another doctor who put drop C now. So then there is irritation, pain, photophobia, stinging, burning, redness is increasing, the lid swelling that I showed you. And now the vision starts getting a little blurry, especially if the cornea is affected. What are the signs you look at? There may be a little punctate staining of the cornea. There may be some small epithelial defects. If it's long-standing, you get these permanent sort of dilated vessels, and there may be a follicular type of conjunctival congestion. And sometimes you can get corneal edema, you can get even pseudodendrite formation, and you can get a disciform infiltrate. So this mimics a lot of conditions. So unless your history is very clear, we've gone properly into many times history is the best indicator that this is a conjunctivitis medicamentosa. So if an infection of the conjunctiva has been treated with topical antibiotics, it has not shown an improvement in a week or 10 days, or has worsened after initial improvement, please suspect conjunctivitis medicamentosa. Stop the antibiotic drops. Replace with simple non-preserved lubricants, frequent use. Patient should feel better within 24 hours or 48 hours. So just stop everything. Sometimes you can just stop and not even add lubricant, or stop and add the lubricants. And then you can, once you feel your diagnosis is made, you can gradually add simple steroid drops, surface acting steroids to the lubricants. Now what about, so I told you about allergy and dry eye, then I told you about conjunctivitis medicamentosa. What about dry eye and infections? Again, many assume that once a patient you have diagnosed as dry eye, you hate that patient because he troubles you, he rings you up, doctor, mera aankh mein thoda khatakta hai, and they don't pay because they are telephonic. So you tell them just put the drops more often. You are putting Gentil 4 times, put it 8 times. You are putting Refresh 4 times, put it 8 times. Whatever he is putting, double the frequency, don't trouble me on the phone. That is the typical reaction to a dry eye patient because you feel that every symptom is attributed to his dry eye. However, dry eye patients are more prone to infections because the ocular surface is challenged. So avoid telephonic treatment. If a patient tells you he is unwell, please call him in, and 2 things can be there. One is there is an associated blepharitis, that's why his symptomatology has changed. There is which you cannot diagnose on the phone. So you need to look for this blepharitis. Unless you aggressively treat the blepharitis, the patient will just not feel better. So there is this squamous blepharitis, it is staring at you if the patient comes in, but it's not staring at you on the phone. Unless you're, who's that fellow Axis Bank and the video phone thing? Karan Johar, I think. Anyway. So you need to call them in. A known dry eye patient presenting with conjunctivitis is not uncommon. Don't overdo the topical antibiotic treatment. Topical antibiotics, especially aminoglycosides, your gentamicins and your topramycins are toxic to the surface and can worsen a dry eye, even neomycin. So treat aggressively for a week or so, and then please stop the topical antibiotics. No conjunctivitis needs to be treated for more than that. And continue the lubricants even when the antibiotic is on. So if there is dry eye and infection, please continue lubricants and add antibiotics for a short period of time. What about allergy and infection? So we talked about allergy and dry eye and infection. Now what about allergy and infection? Yes, kids often are not the cleanest human beings that you will find, and they often rub their eyes with dirty fingers. So it is possible for allergy to coexist with infection. How do you suspect this? On the phone, if the parent tells you that the eye discharge is different, remember they know the eye discharge of allergy because they've treated this patient last 4 years, he's under you. So they know what kind of drop of water comes out in allergy. Tells you the eye discharge is different, immediately call the patient to the office. Treat as a coexisting infection. If besides the papillae, the rest of the conjunctiva is also red. Now in typical allergy, either the upper palpebral is red or around the limbus. If the rest of the conjunctiva is red, treat as an infection. Again, a short course of frequent topical antibiotics and continue with the anti-allergic treatment. Avoid aggressive steroid therapy in diagnostic dilemmas. I have known patients, whenever there is a combination, just load the patient with steroids. They only suppress the symptoms, and sometimes you get new infections and sometimes even fungal infections. Avoid shotgun therapy with multiple anti-infective agents. Again, I've seen this antifungal, antiviral and antibiotic in the same eye. They're a sure recipe for causing conjunctivitis medicamentosa. So to conclude, allergy and dry eye and infection and dry eye, allergy and infections, all these can coexist. We need to recognize these and treat these. Avoid telephonic diagnosis and treatment of chronic dry eye or allergic patients on the phone. Don't overdo anti-infective treatment and beware of conjunctivitis medicamentosa. Thank you so much for your attention.